Good evening. My name is Alberto E Batista. I'm currently a P3 student at Florida A&M University, and today I'm going to be reviewing or discussing a journal article that I read recently about the benefits of statins versus statins plus non-statin therapies for acute coronary syndrome. So what this study did was it actually highlighted the benefits of monotherapy simvastatin versus the benefits of versus Zetia plus simvastatin to treat patients who had experienced acute coronary syndrome. So just a little bit about the actual medications that we're going to talk about and the mechanism of action. We know that Zetia inhibits the absorption of cholesterol at the brush borders of the small intestine, and statins are known to inhibit the HMG-CoA reductase enzyme by preventing the conversion of HMG-CoA to mevalonate. Several studies, have proven that the use of statins to treat patients with acute coronary syndrome have been extremely beneficial. And what they haven't really proven in recent years is that the combination of statins plus a non-statin, I guess the question was, this study was really focused on whether further lowering of LDL cholesterol levels would be achieved with the addition of Zetia to statin therapy, and would it lead to a benefit in clinical outcomes? We didn't know. So what they did was actually conduct a study where they had over 1,147 practice sites in 39 different countries, and they were able to sign up over 18,000 people for this study. In order for you to be part of this study, you had to either be a man or a woman at least 50 years of age who had experienced or who had been hospitalized within the preceding 10 days from an acute coronary syndrome. Acute coronary syndrome in this study is defined as an acute myocardial infarction with or without ST segment elevation or electrocardiography, or high-risk unstable angina. Patients for this study were required to have an LDL cholesterol level of 50 milligrams per deciliter. For participants in this study who were not receiving long-term lipid-lowering therapy, the maximum LDL cholesterol level for enrollment was 125 milligrams per deciliter. But for participants who were receiving lipid-lowering therapy, the maximum level was 100 milligrams per deciliter. And, what they did in this study is all patients who had actually entered, who had been admitted into the hospital, they went ahead and, obtained those LDL cholesterol levels for eligibility. Excuse me. In order for you to be eligible for this study, your LDL levels had to be measured within 24 hours of being admitted into the hospital for acute coronary syndrome. So what this study did was it compared simvastatin to simvastatin-Zetia combo. Patients were randomized in this study, and it was considered to be a double-blinded randomized trial. So what they did was patients, were given these medications, and what we saw was that either you had a simvastatin monotherapy or you had a simvastatin-Zetia combo therapy. For those who received the simvastatin monotherapy, they were given 40 milligrams a day, 40 milligrams QD. And for those who received the simvastatin-Zetia combo, they had simvastatin 40 milligrams plus Zetia 10 milligrams. Patients had follow-up visits at 30 days, at 4 months, and every 4 months thereafter. What we did see was that those patients also received Patients also had blood samples withdrawn at randomization during the first month, 4th month, 8th month, and 12th month, and yearly thereafter for those attending clinical visits. One thing that I saw in this study, was that certain levels for these patients, certain LDL levels weren't being controlled for these patients. So what they did in this study, they actually went and, for both arms in this study, they increased For patients who in either study group who had LDL cholesterol levels higher than 79 milligrams per deciliter on 2 consecutive measures, the simvastatin dose was increased to 80 milligrams in a double-blinded manner. But in 2011, the FDA suggested that simvastatin at 80 milligrams was not beneficial. So those patients had to actually be removed. Well, their dose had to be reduced. So those things could have really affected this study. But at the end of the day, what they were really focused on was finding out if there would be additional benefits of adding a non-statin therapy to a statin therapy, and would it help reduce cardiovascular complications, would it help reduce deaths, would it help reduce different symptoms and outcomes and comorbidities that could develop with patients experiencing acute coronary syndrome. In this study, they highlighted a primary endpoint, and this primary endpoint was a composite of death from cardiovascular disease. That cardiovascular disease was considered a major coronary event such as a non-fatal myocardial infarction, documented unstable angina requiring hospital admission, or coronary revascularization occurring at least 30 days after randomization, or non-fatal stroke. Those were the key things that they were looking to see. They wanted to see, is this simvastatin monotherapy compared to the simvastatin Zetia therapy going to be less beneficial? So they wanted to really see what were going to be the outcomes. What they did was, after conducting, after recruitment of 1,144 patients, they went ahead and created two arms. 9,077 patients were assigned the simvastatin monotherapy group, and 9,067 patients were assigned to the Zetia simvastatin group. So, give me 1 second here. I'm sorry, I apologize here. What we did see was that patients who were actually, after following up for at least 1 year, we were able to really see different benefits. One of those main benefits that we actually saw was that 24% of the patients who were actually treated with Zetia simvastatin compared to simvastatin monotherapy had further lowering of LDL cholesterol levels than had further lowering of LDL cholesterol levels. There's additional things that were reported. The mean LDL cholesterol level was 69.9 milligrams per deciliter in the simvastatin monotherapy group, but it was 53.2 milligrams per deciliter in the simvastatin Zetia group. So we see a big difference there. Additionally, we see a benefit over the course of the entire trial that the median time weighted average LDL cholesterol level was 69.5 milligrams per deciliter in simvastatin monotherapy, and for patients who were on the combo, it was 53.7 milligrams per deciliter. So that accounts for patients in the two groups who also discontinued treatment and did not have blood samples obtained. So at the end of the day, there was a couple things there that I saw in this study that kind of set me back a little bit. We saw extreme benefits of using the combo drug compared to the monotherapy, but the way they went about, people who had been excluded, people who had stopped taking these medications, it kind of highlighted some things that we should go ahead and reconsider about the, is the combo of Zetia and Zocor better than Zocor monotherapy, because here it says to account for patients in the two groups who discontinued treatment and did not have blood samples obtained, LDL cholesterol levels were inputted with the use of an LDL cholesterol levels measured at randomization. So they kind of made up an equation that would benefit, these patients. Additionally, there was another limitation that I saw in this study, which I kind of felt like, maybe we should reconsider to see if that's even, if this combo is more beneficial, because we also have to consider cost, and we don't really know what's going to happen long term just yet. So it says here, that there was a difference between the two groups that emerged after about 1 year, right? By which time most of the data were from patients in the chronic phase of the disease. So, we don't know if for patients experiencing acute coronary syndrome, the combo drug would be more beneficial. The reported data is kind of highlighting that, yeah, it was more beneficial during the later stages of, those complications. There's also a limitation where it says some patients use 40 milligrams and others use 80 milligrams of simvastatin as background statin therapy, which, how do we know that less simvastatin, a lighter simvastatin dose would not be as effective as a heavier or a stronger simvastatin dose? So those are some of the limitations we have to consider. And then 42% of the patients discontinued the study medication for any, it said that 42% of the patients discontinued the study medication for any reason prematurely, with an equal proportion in the two groups. The rate of approximately 7% per year is similar to or better than that achieved in some prior studies. So 42% of these people discontinued the therapy. So, what was reported, how many of those patients were taking the 40 milligram therapy simvastatin, how many of those were taking the 80 milligrams simvastatin therapy? So we don't really know. Those are the things that we have to reconsider in this overall study. So I think there might be a little bit of bias here, and at the end of the day, we just know that simvastatin alone is beneficial, and the combo of simvastatin and Zetia can also be beneficial. So we have to consider cost, we have to consider compliance, we have to consider, is this patient going to be adherent to this medication because it requires, more attention, more medications to be treated. And then we have to consider those factors that could have affected this overall study, such as some patients received a stronger dose of simvastatin initially, while others received a lighter dose of simvastatin initially. Those are things that we have to consider. But overall, the addition of Zetia to statin therapy in stable patients who had an acute coronary syndrome and who had LDL cholesterol levels within guideline recommendations further lowered the risk of cardiovascular events. So, this study was beneficial, but at the end of the day, there were several limitations that we have to consider to determine whether or not a monotherapy statin versus a statin plus a non-statin combo would be more beneficial. Thank you.